Hi everyone, Dr. Beena here. Today we are going to revise the classification and laboratory diagnosis of jaundice. It is an important question for you for your university, usually a 5-mark question. Sometimes classification alone can come with the clinical manifestation and sometimes laboratory diagnosis of jaundice alone. So it is a very important question for your university. So before going to the actual classification and causes, we have to know what is jaundice. Jaundice, you have to define jaundice. Jaundice is yellowish discoloration of skin and conjunctiva and sclera due to increased amount of bilirubin in the blood. So you have to know the normal bilirubin level. So the normal plasma bilirubin level is 0.2 to 0.8 milligram per deciliter, and the unconjugated bilirubin is 0.2 to 0.6, or sometimes it may be 0.7 milligrams per deciliter, or the conjugated bilirubin is only 0.1 to 0.4 or 0 to 0.2 milligram per deciliter. So if the plasma bilirubin exceeds 1 milligram per deciliter, the condition is called the hyperbilirubinemia, that is increased level of bilirubin. That hyperbilirubinemia is termed only when the plasma level exceeds 1 milligram total bilirubin. The levels between 1 milligram and 2 milligrams are indicative of latent jaundice or subclinical jaundice when there is no manifestation or jaundice. Then the total bilirubin, if it is above 2 milligram per deciliter, it is called the clinical jaundice. So the clinical jaundice occurs only when the total bilirubin is above 2 milligram per deciliter with all the symptoms like yellowish discoloration of skin and conjunctiva. Okay. Next we'll pass on to the classification and the causes. So classification, it is mainly divided into 3 types: prehepatic or hemolytic jaundice, hepatic or hepatocellular jaundice, or post-hepatic or obstructive jaundice. So here it is shown in the table like this, but in the first column there is type of bilirubin which is elevated in these classes are shown first. So you can write it as the second column and then it will be easy. So prehepatic jaundice, what is the cause for the prehepatic jaundice? That is before hepatic before bilirubin appear in the before the bilirubin going to the conjugation in the liver, there will be excess formation of bilirubin. You know, bilirubin is the end product or the catabolic product of heme, isn't it? So hemoglobin RBC lysed hemoglobin is produced, then globin part is removed, then the heme is catabolized to bilirubin. Then bilirubin go to the through the blood, it reaches the liver where it is conjugated and it is excreted through bile into the intestine where it is deconjugated and reduced and finally excreted as stercobilinogen in the urine, stercobilinogen in the feces, and some part is reabsorbed to the liver again, and on the way it is going to the systemic circulation and is excreted through urine as urobilinogen. So that is the normal cycle of the heme metabolism. So here prehepatic jaundice is the otherwise known as hemolytic, and the causes are excessive hemolysis or excessive destruction of RBC due to abnormal red cells, antibodies, drugs and toxins, or it may be due to thalassemias, hemoglobinopathies, or Gilbert syndrome or Crigler-Najjar syndrome, which are the two disorders of congenital type of jaundice occurring in newborns. So these are the common disorders where there is excessive hemolysis. RH incompatibility is there in adult, RH incompatibility, autoimmune disease. All these will causes lysis of RBC and that will produce prehepatic or hemolytic jaundice. In all these cases, unconjugated bilirubin is increased. Next one is the hepatic or hepatocellular jaundice, where there is some disorders associated with the liver. So there will be infection and inflammation of the liver, that is viral hepatitis due to hepatitis A, B, C, etc. And then toxic hepatitis due to carbon tetrachloride, chloroform, and some drugs which causes the toxic hepatitis. And there may be intrahepatic cholestasis, that is stasis of bile, that is accumulation of bile due to some intrahepatic causes that may be either infection or inflammation. So whenever there is any liver disease affecting the liver cells where there is infection and inflammation, that will cause hepatic or hepatocellular jaundice. In this case, both conjugated and unconjugated fraction of bilirubin level will be elevated. Then the post-hepatic or obstructive jaundice, where there is obstruction either in the liver or extrahepatic obstruction, producing extrahepatic cholestasis, that is gallstones, tumors of the bile duct, stricture of bile duct, carcinoma, head of the pancreas, then lymph node enlargement in the porta hepatis. All these conditions, after conjugation, the bilirubin cannot be excreted to the intestine. So there will be accumulation in the liver cells, and finally it will enter the systemic circulation, that is blood, and being a conjugated fraction, it is water soluble and it can be excreted through urine. So there will be bilirubin in the urine or bilirubinuria in the case of post-hepatic jaundice, where there is usually the conjugated fraction will be elevated. Okay. Now we can see separately what are the levels of various types of bilirubin in various types of jaundice, that is hemolytic, obstructive, and the hepatocellular jaundice. Total bilirubin will be elevated in all these fractions. So whenever there is elevation above 2 milligram, we can call it as jaundice. So total bilirubin will be elevated in all these fractions. Conjugated bilirubin will be normal in the hemolytic jaundice, but elevated in obstructive jaundice, and some elevation will be there in hepatocellular also. Then unconjugated bilirubin will be elevated in the hemolytic jaundice. That is due to excess hemolysis, more of unconjugated bilirubin will be there. Then obstructive jaundice, it is normal because it is not going to the it is obstruction, there will be normal unconjugated bilirubin, and then it is elevated in the hepatocellular jaundice. So the Vandenberg reaction is the one which test which uh, helps to find out the bilirubin levels, various types of bilirubin levels in the blood. So here we are dealing with the bilirubin in the blood. Total bilirubin elevated in all. Conjugated bilirubin will be elevated mostly in the obstructive jaundice, and some amount will be elevated in the hepatocellular jaundice. Unconjugated bilirubin will be elevated only in the prehepatic or hemolytic jaundice, and a small fraction may be elevated in the early phase of hepatocellular jaundice. So this is the picture of the bilirubin in various types of jaundice separately. Now what is, we have told that Vandenberg reaction is the test by which we can measure the bilirubin. So it is a test, the test is known as Vandenberg reaction, and it is bilirubin estimated by the Vandenberg reaction, where the diazotised sulfanilic acid reacts with the bilirubin to form a purple colored complex called the azobilirubin. That is the principle of the test. So a purple color, intensity of the purple color will be directly proportional to the amount of bilirubin. So normal serum bilirubin to 0.2 to 0.8, unconjugated 0.2 to 0.7, and conjugated 0.1 to 0.4 milligram per deciliter. Then when the bilirubin is conjugated, the purple color is produced immediately by mixing the reagents. That is called the direct positive. So it will be direct positive in obstructive jaundice. When the bilirubin is unconjugated, the color is obtained only when alcohol is added, so that the albumin is extracted. So that is called the indirect positive. That is usually seen in the hemolytic or prehepatic jaundice. If both conjugated and unconjugated are present, there will be immediate color formation, and the color intensity increases when adding the alcohol. That is, after directly adding means conjugated is present. Then when you are extract with alcohol, again the color increase means there is unconjugated fraction also, that is seen in the hepatocellular jaundice, and that reaction is called the biphasic. Now, so in hemolytic jaundice, unconjugated bilirubin is usually increased. So total will be increased above 2 or whatever level it is. The major fraction increased is the unconjugated bilirubin. So Vandenberg test will be indirect positive. In obstructive jaundice, the conjugated bilirubin is elevated and the Vandenberg test is direct positive. So there will be conjugated fraction is the one more elevated in the obstructive jaundice. In hepatocellular biphasic reaction, both conjugated and unconjugated bilirubin are increased. Now urinary bilirubin, that is bilirubin in urine. You have done the test. Force's test is the one which you do to find out the bilirubin in the urine. So in all cases of jaundice, urine should be examined for the presence of bile pigment, bilirubin, and then bile salt and urobilinogen. So all these three tests has to be done. Only conjugated bilirubin is water soluble and excreted through urine. That we already discussed. Conjugated bilirubin is water soluble, so it can be excreted through urine. Hence, the in prehepatic jaundice, when there is only elevated fraction is the unconjugated bilirubin. It does not appear in the urine, and hence it is called the acholuric jaundice. Acholuric means no yellowish color, that is no bilirubin in the urine. Only the urobilinogen is increased. So in prehepatic or hemolytic jaundice, bilirubin will not be seen in the urine. Okay. Next, urobilinogen. In case of obstruction, bile is not reaching the intestine. We have, in the types we have studied, there will be obstruction in the liver or extrahepatic obstruction. So the bile is not reaching the intestine, and so urobilinogen may be decreased or absent in the urine. So there won't be any production of urobilinogen. So there won't be urobilinogen in the urine that is occurring in the obstructive jaundice. In hepatocellular jaundice, urobilinogen is initially elevated and decreases or disappears when there is obstruction in the liver, and again reappears when the obstruction is cleared. That is in hepatocellular. Early phase there will be elevated urobilinogen, then it will be decreasing or even absent, and again it will be reappear when there is no obstruction or recovery stage. It is increased. Okay. So the urobilinogen is absent in urine when there is obstruction to the bile flow. Then hemolytic jaundice, urobilinogen is increased. So that is the two types we can distinguish by the urobilinogen. Urobilinogen absent in the urine in obstructive jaundice, and in hemolytic anemias or hemolytic jaundice, urobilinogen will be increased. Bilirubin is detected by the Forcher's test and urobilinogen by Ehrlich's test. Now you have done the bile salts also, urinary bile salts. Normally bile salts are present in the bile but are not seen in the urine normally. Bile salts in urine is detected by the Hayes test. You have done the test, you may be remembering. Positive Hayes test indicates the obstruction to the biliary passage causing regurgitation of the bile salts into the systemic circulation, leading to its excretion in the urine. So when there is positive Hayes test, that means there is a regurgitation of the bile salt through the bile into the systemic circulation, leading to the excretion in the urine. So Hayes test done with the sulfur powder and all. Sulfur powder sinks means that is due to the presence of bile salts that is present in usually in the obstructive jaundice. So finally you can make a column table like this and explain the differential diagnosis with all the findings, blood and urinary findings. Specimen 1 column test, what test is you doing, then the 3 types of jaundice. Blood unconjugated bilirubin or Vandenberg indirect positive, that is plus in prehepatic or hemolytic. 1 plus, it may be present in hepatocellular jaundice and it is normal in the post-hepatic jaundice. And blood conjugated bilirubin Vandenberg direct positive, it is normal in hemolytic jaundice. It is excretion rate, it is rate limiting, it is first impaired activity, and the early phase it is increased. So the conjugated fraction may be increased in sometimes in the hepatocellular jaundice. Post-hepatic, it will be definitely elevated, and the direct positive reaction, the total bilirubin, out of the total bilirubin, majority will be the conjugated bilirubin. Then the blood, again, one more test you can do is the alkaline phosphatase, 40 to 125 international units per liter normal. It is normal in prehepatic because there is no affection of the liver. Then 2 to 3 times increased in hepatocellular jaundice. The level is 2 to 3 times more increased because there is some infection in the liver, and then the alkaline phosphat is produced by the liver biliary canalicular cells also apart from the bone. Then it is 10 to 12 times increased in the post-hepatic or obstructive jaundice. So it is again a diagnostic marker of the post-hepatic or obstructive jaundice. Okay. Now we are pass on to the urinary findings. So first, bile salts by Hayes test, absent in hemolytic jaundice, usually absent in the hepatocellular, but it is present in the post-hepatic jaundice. So whenever there is obstruction, bile salts regurgitate to the systemic circulation going through the kidney and excreted. Similarly, urine bilirubin by Fort's test, absent in hemolytic jaundice, and it is present in the hepatocellular jaundice and also present in the post-hepatic or obstructive jaundice. So bilirubin being conjugated bilirubin by being water soluble, it is excreted through the urine. Then urobilinogen by Ehrlich's test, it is 3+. It is highly elevated, seen in the prehepatic or hemolytic jaundice, but it is increased in the early phase of hepatocellular jaundice, and later on it may be absent. And reappearance again shows that there is improvement of the hepatocellular jaundice. And it is completely absent in the obstructive jaundice. Remember, urobilinogen completely absent in the urine, will be completely absent in the obstructive jaundice. Then about the feces. Feces contains urobilinogen, that is stercobilin or urobilin. It will be present in the hemolytic jaundice because there is excess hemolysis and more production of urobilinogen. More is going to the intestine, and so more is reduced and reconjugated and excreted through feces. Then it may be normal or slightly decreased in hepatocellular jaundice, and it is clay colored. Clay colored means it is decreased. Level is almost nil in the obstructive jaundice due to the obstruction of the enterohepatic circulation and all. So there is no stercobilinogen in the feces, which gives a clay colored stool in the obstructive jaundice. So these are the various lab diagnostic features which you can detect the various or diagnose the or differentiate various types of diagnosis. Okay, so study this thoroughly so that it is usually asked for the viva and also for your exam abnormal urine analysis. There will be bile salt and bile pigment, so they will ask all questions like this. And classify jaundice causes, you have to refer your test and get the details. I am just revising it only. Then the lab diagnosis, you can make a column like this, write the blood, urine and feces findings separately, and so you'll get good mark. Wish you all the success. Thank you.